In this part, I'm going to briefly discuss diagnostic tests for cardiovascular function, and then we'll start talking about heart disorders, and that will continue with the rest of the lectures, the disorders. So lots of different tests for cardiovascular function, electrocardiography, or ECG, otherwise known as EKG. They use it for initial diagnosis and monitoring of dysrhythmias, myocardial infarction, infection, and pericarditis. Auscultation is listening with a stethoscope. I took a workshop several years ago, and I was really excited about it because I worked with a lot of people with heart problems, and they were supposed to talk about, it was cardio and respiratory physical therapy. It was the most boring workshop I'd ever been to. I was so disappointed. But they talked a lot about auscultation and the different things you can diagnose with auscultation, and that'd be neat if I ever got to do that, but I don't. Too bad they didn't. It wasn't a better workshop, but I had high hopes for it. Anyway, listening through the stethoscope. Echocardiography, you get an echocardiogram as the output for that. It's used to record heart valve movements, blood flow, and cardiac output. So the picture on the right here is some of the output from electrocardiography. Exercise stress tests, they monitor your heart while you're doing running on a treadmill or doing other exercise stress tests. Chest x-ray, used to show the size and shape of the heart. Nuclear imaging can use to track circulation through the heart, and tomographic studies where they can see the different sections of the heart. Cardiac catheterization, they can measure the pressure within the heart and the arteries and assess valve and heart function. When they insert the catheter into the iliac artery, they can go all the way up to the heart with it, and they can put a little camera in there and see what's going on too. They can also break plaques, open up some arteries, and put stents in when they do cardiac catheterization. Angiography is visualization of blood flow in the coronary arteries. Doppler studies assess blood flow in peripheral vessels, and they record the sounds of blood flow or obstruction. So it sounds different if the artery is obstructed versus not. And they do that with the Doppler studies. They use Doppler studies also to assess whether or not there's a thrombus or a clot. So blood tests for cardiovascular function, level of serum triglycerides, cholesterol, sodium, potassium, calcium, all those electrolytes we talked about back in Chapter 2. And arterial blood gas determination checks the current oxygen level and the acid-base balance in the blood. So general treatment for cardiac disorders, if you go see a cardiologist or you have cardiac things, they're going to tell you to make dietary modifications, decrease your total fat intake, weight reduction in general, reduce salt intake, regular exercise program. We love that. Send them to physical therapy. We'll give them a regular exercise program. Exercise increases high-density lipoprotein levels, lowers serum lipid levels, and reduces stress levels. It's all good for your heart. Stopping smoking, always a good idea, and it decreases your risk of coronary disease. So drug treatment is really common for cardiac disorders. There's a whole list of different cardiac drugs that are generally used. Vasodilators like nitroglycerin, they dilate the peripheral blood vessels, so they are reducing peripheral resistance, and the heart doesn't have to work as hard. Beta blockers are used in treatment of hypertension and dysrhythmias and reduction of angina attacks. Basically, they want to lower your blood pressure by dilating the blood vessels. Again, if you are treating a patient that's on beta blockers, and you can't have them monitor their exercise by using their heart rate, because their heart rate will not go up in response to exercise. So you have to teach them to monitor their exercise by perceived exertion, and that's certainly doable. But that's a good thing to know, what drugs your patient is taking, so you know how to adapt their treatment accordingly. So calcium channel blockers decrease cardiac contractility. They're antihypertensive and vasodilators, and they are prophylactic against angina. So the calcium channel blockers, they dilate coronary arteries specifically, and they suppress some dysrhythmias. So those are often used. Digoxin is a lot of times used for controlling atrial dysrhythmias and for treatment for heart failure. There are some new drugs out there that they're using for atrial dysrhythmias, but it really, since the drugs are not the main focus of our physical therapy practice, it's nice to know the common things that people are on, but it's practically impossible to keep up with all the latest medications. But this is just kind of a general, just a lot of our patients are on cardiac medication, so it's good to know what types of medications are being used. So antihypertensive drugs, blood pressure drugs, they're used to lower blood pressure. Androgenic blocking drugs, they act on the sympathetic nervous system, either centrally or on the periphery, and again that's to increase vasodilation or decrease vasoconstriction and lower the peripheral resistance. Angiotensin converting enzyme inhibitors, or ACE inhibitors, they function in that renin angiotensin aldosterone pathway to block conversion of angiotensin 1 to angiotensin 2. So it prevents that particular pathway from raising your blood pressure, from increasing your blood volume. And those are the ACE inhibitors are really commonly used in combination with diuretics. So there's actually a combination drug that's a ACE inhibitor diuretic combo that a lot of people are on for high blood pressure. Diuretics remove excess sodium and or water from the system. They treat high blood pressure and congestive heart failure. Anticoagulants reduce the risk of blood clot formation. So there are the platelet ones specifically, like Plavix, and there are a couple other brand names. And then warfarin or Coumadin, which is a common anticoagulant. And then the newer class of drugs, the Xarelto and not remembering that other one, but it's in the Xarelto class. Cholesterol lowering drugs to reduce LDLs and cholesterol levels. So this is the table from the book that shows selected cardiovascular drugs, their use, their action, and potential adverse effects. You notice that a lot of times the adverse effect is dizziness, and sometimes headache. So that's a common side effect for cardiovascular drugs. So we're going to start talking about disorders, coronary artery disease, and acute coronary syndromes, sometimes they're called. So coronary artery disease includes angina pectoris, or temporary cardiac ischemia, myocardial infarction, or heart attack. So when we talk about coronary artery disease, all of those are included. So coronary artery disease usually starts with arteriosclerosis and atherosclerosis. Arteriosclerosis is a general term for all types of arterial changes. Generally, in medical terminology, sclerosis means hardening, so you can think of arteriosclerosis as hardening of the arteries. So there are degenerative changes in small arteries and arterioles that result in a loss of elasticity. The lumen, the inside of the artery, gradually narrows and may become obstructed. And it increases peripheral resistance, so it can cause increased blood pressure. So atherosclerosis is in larger arteries, and there's the presence of the atheromas, which are plaques in the large arteries, and the plaques consist of lipids, calcium, and possibly clots. And then when those plaques are there, they're sticky, and the thrombocytes can stick to them, and then more stuff sticks to them, and they can eventually obscure the arteries as well. Atherosclerosis can be related to diet, exercise, and stress. So this picture shows an obstructed artery and an unobstructed artery. So it's interesting. Lipids are transported in our blood in combination with proteins. So the LDLs, low density lipoproteins, they're the bad cholesterol. So they have this little picture, the little LDL's bad and the HDL's good. Another way that I've heard it to remember which is the LDLs are the lousy lipoproteins and the HDLs are the happy lipoproteins. But LDLs can be a major factor contributing to atheroma formation. They are transporting cholesterol from the liver to the cells. High density lipoproteins, they transport cholesterol away from the peripheral cells to the liver. They're the good ones. They take the cholesterol to be broken down in the liver and then excreted. So when you get your total cholesterol results, it's the LDL plus the HDL. They usually want you to be under 200 for total. And then there's a certain proportion of LDL to HDL that they want you to have, so that LDLs can't be too high and the HDLs can't be too low. So this is the picture from the book with the upper part is a normal aorta with the nice smooth lining and openings into those branching arteries that are nice and wide open. And the bottom is an atherosclerotic aorta. The surface is rough and there's blocked openings to some of those branching arteries. So never a good thing. So the risk factors, there are some risk factors that you're just stuck with. They're non-modifiable. You can't change them. Your age, your gender, and your genetic background. So I always say you have to pick your parents well. I guess it's too late now, right? So you can't change that. It is what it is. But there are things that you can change. Obesity, get rid of that. Sedentary lifestyle, forget it. Stand up right now and go walk around the block. It's hard when you're in school. I know you're kind of forced to be sedentary for a lot of the time. Cigarette smoking, stop doing that. Keep your diabetes under control if you have it. Keep that hypertension under control if you have it. And the combination of oral contraceptives and smoking is a bad idea. But hey, you already quit smoking, so you don't have to worry about that. So the way they diagnose atherosclerosis is they look at your serum lipid levels. So that's your cholesterol level, and your triglycerides. That's another storage form for lipids. To treat it, the doctor usually wants you to lose weight. And you're going to increase your exercise, so that'll be good. And then in the earlier slide, you were improving your diet, so that's going to help you with your weight loss too. A lot of times, good doctors will refer you to a dietitian or a nutritionist so they can help you improve your diet. You want to lower your total serum cholesterol and LDL levels with dietary modification. However, if you are a person that has the right genes for the cholesterol processing, or the wrong genes, I guess, just dietary modification may not be enough, and you also might need some medication. Reducing sodium intake, controlling hypertension, stop smoking, anti-lipidemic drugs. Those are the ones, if your dietary modifications don't do everything, you might have to get on those too. And sometimes surgical intervention like a coronary artery bypass graft. because the LDL was stacking up too many lipids in your arteries, and the HDL couldn't take it all away. So here's your coronary artery bypass graft. They actually take a leg vein, they rotate it so the valve is upside down, and they graft it to bypass the blocked artery. So they call it a cabbage, and if sometimes you'll hear people say they got a triple bypass or quadruple bypass, that means they bypassed 4 different arteries. And so they'll say cabbage times 2, cabbage times 3, cabbage times 4 when you see it in the hospital, and that just means how many arteries they bypassed with a venous graft. It works too. So angina pectoris means chest pain, basically. It occurs when there's a deficit of oxygen to meet myocardial needs. So chest pain can occur in different patterns. It can be classic or exertional angina, meaning you're shoveling snow and you have chest pain because there's a lack of sufficient oxygen to meet your myocardial needs. And then you rest and it goes away. Variant angina, you have vasospasm that occurs at rest that causes chest pain. And unstable angina, even when you rest, you're still having chest pain, and that may precede a myocardial infarction. So never a good thing. So they describe it as recurrent, intermittent, brief episodes of substernal chest pain. It can be triggered by physical or emotional stress, so not just physical stress, but emotional stress too. Attacks vary in severity and duration, but become more frequent and longer as the disease progresses. It's usually relieved by rest and the administration of coronary vasodilators, such as nitroglycerin. Primarily acts by reducing systemic resistance and decreasing the demand for oxygen. So, like, say we have somebody in physical therapy who has angina. So you're having them do whatever activity you're doing. Maybe we're doing some exercise and they have chest pain. They tell you they're having chest pain. First thing you want to do is rest. You want to stop what they're doing right then. Normally people are more comfortable and they breathe better in a seated upright position. If the person is known to have angina and they have nitroglycerin on them, we, of course, do not administer medications, but you can ask your patient, do you have your nitroglycerin with you? And they say, yes, it's in my purse. And you go grab it for them, and then they administer it, put it under their tongue. We can monitor their vitals, check their pulse and respiration. We can administer oxygen if necessary. If it still hasn't gone away and they have their nitroglycerin with them, they can take a second dose of nitroglycerin. If this is a patient who hasn't had a history of angina and they have the sudden onset of chest pain, that is a good time to call 911. Or if you're in the hospital, to call the nurse right away. Get them over there and get some emergency medical aid. So a lot of times I will, even if the patient has been through this before, and if they have to go through and take 2 doses of nitroglycerin, I will recommend to them that they call their doctor. I have even called if maybe someone wasn't sure if they wanted to go in or not. I've called the doctor's office while they were right there and said, hey, this is Loretta from the Grable Therapy and Wellness Center. I've got Mr. Jones here. He's having some chest pain. He's already taken 2 doses of his nitroglycerin, and it hasn't subsided yet. I would recommend that he goes to the emergency room. Do you concur with that? Sometimes I'm just looking for the doctor to give me extra weight for my recommendation of going to the emergency room. And a lot of times, once you go through that process, the patient will go and do that. Because angina can be a lead up to a myocardial infarction, and I really don't want to have that happen. So the myocardial infarction, otherwise known as a heart attack, occurs when a coronary artery is totally obstructed. So the most common cause of myocardial infarction is atherosclerosis. A thrombus from an atheroma might obstruct an artery. So that atheroma, that plaque, it attracts clots, and the clot may break off and obstruct a smaller artery. Sometimes vasospasm is a cause in a very small percentage of myocardial infarction. The size and location of the infarct determine how much damage there is. So what arteries are blocked and what tissues are involved. So the warning signs of heart attack can be different for men and women, but generally it's a feeling of pressure, heaviness, or burning in the chest, especially with increased activity, sudden shortness of breath, weakness or fatigue, nausea or indigestion, anxiety and fear. That's legit. You're not getting enough oxygen to your heart. Pain, they might have pain or they might not have pain, but if it's present, it might be substernal, crushing and radiating down the left arm. That tends to be the pain pattern in men. With women, they can also have neck and back pain and sometimes jaw pain. So women's pain patterns tend to be a little bit different from men's. So definitely take any of these warnings seriously, because heart attack is a serious thing. So when the person goes in for their heart attack, goes into the emergency room, they're having those symptoms, the first thing they're going to do is they're going to do an EKG, and they will see changes in their EKG. They see changes in blood levels, serum levels of enzyme and isoenzymes. A lot of times they're increased cardiac enzymes because there's damage being done to the cardiac muscle. The serum levels of myosin and cardiac troponin are elevated because of the damage to the heart muscle. Leukocytosis, so increased white blood cells, and elevated C-reactive protein, and elevated erythrocyte sedimentation rate are also common. Arterial blood gas measurements might be altered because we have some problem with oxygen transport, and pulmonary artery pressure measurements can be indicative of what's going on as well. Complications of MI, sudden death, that's a bad complication. Cardiogenic shock, so it's inadequate perfusion of oxygenated blood caused by the problem in the heart. Congestive heart failure, that's another complication. Rupture of that necrotic heart tissue causing cardiac tamponade. So if the tissue's damaged enough that you get a rupture, now there's blood going out into the pericardial sac. The pericardial sac fills up with the blood and compresses the heart, doesn't allow it to move. That's called cardiac tamponade. It's very serious. Especially with a left ventricular myocardial infarction, a thromboembolism can cause a CVA, a stroke. So what happens is a clot inside the left ventricle goes out through the aorta and up to the carotid to the brain and causes a CVA. Sometimes it's referred to as throwing a clot. So it's treated in the hospital, in the emergency room. They try to reduce cardiac demand. So, they get them to lie down. Oxygen therapy, analgesics for the pain, anticoagulants to reduce the peripheral resistance. Thrombolytic agents may be used to break up clots. Tissue plasminogen activator, again to break up clots. They use medication to treat dysrhythmias, hypertension, congestive heart failure, and cardiac rehabilitation begins immediately. So when they're in the hospital, they're usually seeing us for physical therapy, and as soon as they're discharged from the hospital, they are going to cardiac rehab to retrain their heart, basically. I was looking at stuff on the internet, and I found this neat little nursing mnemonic and tips chart about the medications that they give. Of course, we don't give medications, but they have a little mnemonic for remembering which medications are given for the immediate treatment of myocardial infarction. And so I thought that was, a pretty interesting little chart. We do not need to memorize those, but there you go.